Record on this.
Thank you for attending 2024 Oncology Coding Updates. Our speaker today is Rachael Willeford, Coverage and Reimbursement Specialist in ASCO's Care Delivery Department. Rachael is a certified hematology encoder with over a decade of oncology revenue experience in multiple practice settings. She acts as a main point of contact for billing and coding inquiries, in addition to producing oncology-focused educational resources for provider and practice support. Rachael serves as a staff liaison to ASCO's American Medical Association activities, including the CPT editorial panel and the RVS update committee. Outside of her ASCO role, Rachael volunteers her time as an officer for a local chapter of the AAPC, a national organization for the business of healthcare. Now I'll turn it over to Rachael. Thank you, Rachael, for presenting today.
Thank you, Allison. So today we're here to talk about the 2024 coding updates that will be affecting oncology. Coding changes can affect practice reimbursement, and being prepared can save a practice both time and money. The American Medical Association updates CPT codes annually with a fall release, with those codes going into effect on January 1st. ICD-10-CM codes are released by the Centers of Medicare and Medicaid Services on an annual basis with the effective date of October 1st. And finally, HCPCS codes are released by CMS on a quarterly basis. ASCO distributes resources to coincide with each of the regularly issued coding updates. We will begin with CPT updates first. So CPT codes are proposed, reviewed, and approved 3 times a year at the CPT editorial panel meeting held by the American Medical Association. Approved codes are then added to the CPT Professional Edition with the year dependent on the CPT schedule. Specialty societies like ASCO advocate for their members and their specialty by participating in this process. For the 2024 year, the CPT editorial panel has eliminated time ranges for the office and outpatient service visit codes and instead created specific time that must be met or exceeded to report each office visit code. Because the E&M codes require a time threshold for reporting, the midpoint rule does not apply to these codes. In recent years, there's been a deviation between Medicare and the CPT and RUC recommendation of codes. The American Medical Association added language in the E&M guidelines to clarify how to report split shared services. And in doing so, CMS has adopted those guidelines in their definition. So what exactly is the CPT language clarifying? Split shared services can still be chosen based on time or medical decision making. Selecting the reporting provider based on time would be determined by the physician or other healthcare professional who spends the majority of the total time performing services on the date of the encounter. This, of course, would include both face-to-face and non-face-to-face time. However, if split shared code selection is based on medical decision-making, the practitioner must make or approve a management plan for the problems addressed at the encounter and assume responsibility for the risks of complications and comorbidity or mortality that are associated with that treatment as part of the management plan. Now, a caveat to this is if data is used by the provider to determine the level of service. Most data elements don't have to be personally performed by the billing provider on the date of the encounter. However, they can be shared and performed by the other provider on that encounter. The exception is independent interpretation of tests and discussion of the management of the patient or the test interpretation. Those must be personally performed by the reporting physician or qualified healthcare professional. Other clarifications were added for multiple visits occurring over the course of a day, with per day defined as a single calendar date. So all services on a single day in the same setting are reported with a single service, and the level of service determined by the combined time or medical decision-making. If a patient is discharged and readmitted on the same day, a subsequent care service would be reported instead of a discharge or initial service, as this would constitute a single stay. Now, if this is in different settings, multiple E&M visits in different settings, guidance provided in 2024 now reflects the concept of separately reportable services. That's sometimes referred to as double dipping or no double dipping. Time and activities from one service cannot contribute to that of another service in a different setting. Prolonged services would be reported based on their relationship to the primary service. So also to report separate services in two facilities, a discharge from one facility to another is required. Now, if the patient's transition between office and the ER or another facility, or even vice versa, and only one service is reported, the time or medical decision-making is combined to comply with per-day guidelines. Prolonged services reported in this situation would be appropriate for the primary service reported, regardless of the patient location. And the choice of primary service is at the discretion of the physician or qualified healthcare professional. For example, if we have a physician that has seen a patient in the office that he or she's been seeing for metastatic cancer, and that patient came in for regular follow-up to discuss interval imaging prior to receiving chemotherapy. During the evaluation, the patient's labs indicated severe anemia, and so the doctor decides to admit the patient. The doctor then saw the patient and did an initial hospital visit, and in that encounter, ordered a complete workup for the anemia and ordered additional tests to determine the cause, and ordered also blood transfusions to treat. So in this instance, the time or medical decision-making can be combined and reported into one service. Now, according to CPD guidelines, the physician could also choose to report these services separately if the documentation supports these as separately identifiable procedures. Hospital inpatient and outpatient service codes are per-day codes. And it seemed that CPD guidelines and CMS guidelines were contradicting one another. So for 2024, there's additional language that's appearing in the CPT manual that clarifies the reporting of admission and discharge coding. And it's now consistent with that of the CMS 8 to 24-hour rule. These services are only reported by healthcare professionals who perform both the initial and discharge services. Any other physicians and qualified healthcare professionals would report the initial and subsequent hospital and observation service codes as appropriate. So if a patient is in the hospital or observational setting less than 8 hours, the billing provider would report an initial service only. If the patient is there for over 8 hours but still discharged on the same day, an admission and discharge code would be appropriate to report. And finally, if the patient is discharged on a different day, an initial hospital code would be used as well as a discharge management code. Another topic receiving additional clarification language is that of the unlisted codes. To describe a procedure performed with the highest level of specificity to describe the procedure performed, it might require reporting an unlisted code in addition to a Category 1 or perhaps a Category 3 code. For example, if there's a separately reportable portion of the procedure that isn't described by any existing code, it may be appropriate to report an unlisted code that describes just that portion of the procedure. Now, multiple separately reportable unlisted codes may also be reported, but the procedures must be performed on the same patient, on the same date, by the same physician or qualified healthcare professional. For example, if unlisted procedures are reported in different body regions, there may be multiple unlisted codes. And additionally, CPT guidelines now instruct us as to which modifiers are allowed to be added to unlisted codes. such as the bilateral or laterality codes, the assistant at surgery, and telehealth modifiers, if that unlisted code is approved for telehealth. Now, there are not many oncology situations that apply to unlisted codes, but healthcare is a continually evolving field. Unlisted codes allow for the reporting of new or existing services that may not otherwise be reported with current CPT codes. Also, keep in mind that appropriate Category 1 or Category 3 codes should be reported first rather than reporting unlisted codes as a component of the procedure. For example, whole body CT scans are sometimes reported with the unlisted CPT procedure. But if you follow CPT guidelines, it would actually be appropriate to report each body part that was evaluated during the imaging procedure, like reporting the 70470 for the head, 74178 for the pelvis, and a 72130 for the thoracic CT of the spine. Instead of the whole thing, you break it down into parts. However, this is an example of how payer policy can differ from CPT guidance. In this case, many payers actually require the unlisted code rather than the separate body parts. There are 3 additional codes added in 2024 that may see some oncology applications. The first is HIPEC procedures, or intraoperative hyperthermic intraperitoneal chemotherapy. This is reported with the 96547 for the first 60 minutes, and each additional 30 minutes would be reported with the 96458. Both of these codes are add-on codes, meaning that a primary procedure must be reported as well. In this case, a surgical procedure would be reported as the primary procedure indicated by the code in the CPT manual. Now, to distinguish 96446, which is for chemotherapy administration in the peritoneal cavity, from that of HIPEC chemotherapy, the descriptor of the 96446 was revised. Now it indicates chemotherapy administration from an implanted catheter rather than that of an indwelling catheter. The CPT editorial panel also approved the creation of 99459 for pelvic examination. This was originally proposed to assist ER and primary care providers who may be performing pelvic examinations during encounters. This code is not limited by specialty, though, and can be reported as an add-on code to primary evaluation and management services. Moving on to diagnosis coding. So the ICD, or International Classification of Disease Codes, are copyrighted by the World Health Organization. In the US, ICD-10 CM codes, otherwise known as diagnoses codes, are developed and maintained by the CDC's National Center for Health Statistics. These codes are used to report the diagnoses associated with services, procedures, and supplies provided in healthcare. The 2024 update to the ICD-10 CM code set has codes for neoplasm, hematology, signs and symptoms, and factors influencing health status, or the Z codes that are oncology related or oncology adjacent. We will cover neoplasm related updates first. The first 2 additions are benign neoplasms indicated by D13.91 for familial adenomatosis, polyposis, a risk factor for colorectal cancers, as well as D13.99 for benign neoplasm of ill-defined sites within the digestive system. D13.99 is also reported for benign neoplasm of the spleen, as well as not otherwise specified reports in the digestive system and the intestine. Added to the diagnosis code list are codes for desmoid tumors, a non-cancerous growth occurring in the connective tissues, usually occurring in the abdomen, arms, and the legs. An additional code was added to this family as an otherwise specified code to indicate an otherwise specific neoplasm of uncertain behavior of connective and other soft tissues. Now, as a reminder, uncertain behavior diagnoses must be supported and indicated by pathology. These are not unspecified codes. In diagnosis coding guidelines, an excludes one indication means that a specified condition cannot be reported with another indicated condition. In this case, previously a benign carcinoid tumor of the large intestine or the rectum, or that of a polyp of the colon that's otherwise not specified, could not be reported along with the benign neoplasm located in the colon, rectum, anus, or the anal canal. In 2024, this indication has been changed to an excludes two indication, meaning that while the indicated code is not a part of the primary diagnosis code, it may be acceptable to use both the primary code and the excludes two code if it's supported by medical documentation. Hematology codes, while not always oncology related, are oncology adjacent. Many oncologists are also hematologists. So in the 2024 updates, the first of the hematology updates is sickle cell disease, coded with dactylitis, also known as hand-foot syndrome. Dactylitis is a common symptom which is associated with pain and swelling in the hand and feet in patients with sickle cell disease. Next is the addition of D61.02 for Schwachman-Diamond syndrome. This is a genetic disorder characterized by short stature, exocrine pancreatic insufficiency, and bone marrow dysfunction. Coding guidance has instructed to code also a few clinically associated conditions, such as AML, or acute myeloblastic leukemia, pancreatic insufficiency, myelodysplastic syndrome, and the genetic susceptibility for other malignant neoplasms, if that is applicable. Lastly, guidance was revised for 3 hematologic conditions to code additional conditions if applicable. In myeloid leukemia, pancytopenia should also be coded if documented. Eosinophilia should be coded in addition to the other specified leukemia if indicated. And finally, if the patient has neutropenia and a mucocytosis is also documented, applicable code should be reported as well. Cancerous cachexia is an oncology-related wasting syndrome. E88.A was added in the codes for 2024 to report a wasting disease or syndrome due to an underlying condition. This code includes cachexia that is caused by an underlying condition, and the underlying condition would be coded first. Cachexia that is not otherwise specified and nutritional marasmus cannot be coded together with E88.A. However, failure to thrive can be reported in addition to the E88.A code if applicable per documentation. Z codes can add additional information to show complexity and conditions of a patient's story that would otherwise be unknown, especially with social situations. New caregiver compliance codes were added beginning in 2023. Now, this year in 2024, additional codes were added to further describe situations of noncompliance with the added specifications of caregiver noncompliance due to financial hardship with a medication regimen, renal dialysis, and other medical treatment, as indicated by code Z91.A41, A51, and A91 respectively. Other reasons are indicated with each of these treatments by the presence of an 8 in the 6th character. Z91.85 has been added for 2024 to indicate a patient's personal history for military service. While a personal history of military deployment isn't included in that of the history of military service, Z91.82 can be coded alongside that military service as it would apply to the patient. And for HCPCS updates. While the HCPCS manual is published annually, the code set updates are released quarterly by the Center of Medicare and Medicaid Services. We will cover additions related to oncology that will be added to the manual for 2024. First is bendamustine. So bendamustine was first known in the US under the brand name Treanda and is reported with J9033. Recently, the industry has seen additional formulations of this drug with market releases of Bendeka and Belrapzo. In 2023, additions of Vivamusta and bendamustine formulas from the manufacturers Apotex and Baxter were introduced and are reported with the codes J9056, J9058, and J9059, respectively. In addition to bendamustine, there are 15 additional drugs or biologicals that will appear in 2024. C9145 was added for aprepitant, which is an antiemetic by the manufacturer Aponvie. Epkinly, an immunotherapy, was first assigned to C9055 and now has a permanent J code of J9321. This drug is used to treat relapsed or refractory diffuse large B-cell lymphoma, as well as high-grade B-cell lymphoma. J1449 is assigned to Rolvedon, a growth factor indicated for febrile neutropenia. J1954 is used to report leuprolide acetate that is manufactured by Cipla. Leuprolide acetate is indicated for advanced prostate cancer. J9029 was added for Adstiladrin, a gene therapy used for patients with specific forms of non-muscular invasive bladder cancer. And then Elahere, which is an immunotherapy used to treat ovarian, fallopian, and peritoneal cancers, was previously assigned C9146 earlier in 2023 and now has its permanent HCPCS code of J9063. Rolling along, Columvi has been assigned to J9286. This is a T-cell antibody for relapsed or refractory diffuse large B-cell lymphoma, or that of large B-cell lymphoma resulting from follicular lymphoma. J9345 is assigned to Zynes. This is a monoclonal antibody used in the treatment of Merkel cell carcinoma. Imjudo is a monoclonal antibody used in conjunction with Imfinzi or by itself. That's used to treat hepatocellular carcinoma, as well as metastatic non-small cell lung cancer. This drug was originally assigned to C9147 and now has been assigned to J9347. J9350 is assigned to Lunsumio. This is an immunotherapy used with relapsed or refractory follicular lymphoma. And then originally assigned to C9148, Tecvali is now assigned to J9380. Tecvali is an immunotherapy used to treat relapsed or refractory multiple myeloma. Biosimilars are typically assigned to Q codes, and we have those here. 4 biosimilars were added in 2023. The first is Olympus. This is a bevacizumab biosimilar whose reference drug is Avastin. Olympus was originally assigned to C9142 and has since received a permanent J code of Q5126. Another bevacizumab biosimilar, Vexelma, is assigned to Q5129. Neulasta has several biosimilars, with the latest biosimilars being Stimifen and Filnetra. Stimifen is assigned to Q5127 and Filnetra to Q5130. There's a phrase seen a lot lately in CMS's HCPCS updates that is not therapeutically equivalent. So CMS creates product-specific codes which meet the definition of a single-source drug or biological. Here recently, CMS conducted a review to identify products which are not therapeutically equivalent to their reference drug, as indicated in the FDA Orange Book. And and are not within the same billing and payment codes as another drug or biological. So in 2022, CMS then established or revised codes to separately identify these drugs that have been previously reported with not otherwise classified codes, and continues to do so with all subsequent code applications. There have been 4 codes added to the formulations of bortezomib from Dr. Reedy's, Pernicious cabi, Hospira, and Maya that are not therapeutically equivalent to the J9041, which was created to report the reference code Velcade, the original bortezomib. These additional formulations also include the manufacturer in their description, indicating that there is a difference in the formulations. An additional code was also created to report formula variations that are not otherwise specified, which is under the J code J9044. Pemetrexed is also known under the name brand Alimta. In 2022, Pemfixy entered this market, creating the need for a not otherwise specified code for Pemetrexed, which is J9305. In 2023, there are additional formulations of this chemotherapy drug that came out that were released, resulting in an additional 5 codes for each manufacturer formula. An additional code was also created for Pemetrexed dithromethamine, rather than the Pemetrexed disodium formula that's typically been used. And also a code for Pemridi, which is a ready-to-use formulation based on the reference drug. In 2023, Teva and Pernicious cabi have introduced a formulation of fulvestrant with assigned codes J9393 and J9394 respectively. And finally, there are 5 additional codes that are have been added as not therapeutically equivalent to the reference codes of decitabine, Amend, Jevtana, Taxotere, Gemzar, methotrexate, and Abraxane. A request was additionally made to discontinue J9160, which is used to report ONTAG. Now, this drug was withdrawn from the US market in 2014, and therefore the J code is no longer needed. There are 2 modifiers that we saw added to the HCPCS manual. The first is the LU modifier that is used with CAR T or chimeric antigen receptor T cell therapy. When CAR T services are billed on one line item, an issue can arise due to the dollar amount that is billed. On the actual claim itself, the dollar amount billed is restricted to 8 digits, and so not all of it may transmit. To circumvent this, CMS has issued instruction that CAR T services should be divided by 10 and billed in 0.1 fractions. The modifier LU would be added to the claim line to indicate that the services have been fractionalized. Now, additional modifiers may apply to this service. I do recommend referring back to MLN Matters article MM12928 for additional information. Never fear, I have provided a link in the resource section of this presentation to this specific MLN Matters article. The next modifier is the JZ modifier that indicates that there's no drug wasted on a claim. When using single-dose vials, Medicare requires the use of the JW modifier to indicate amounts that were wasted. Modifier JZ was required by Medicare starting on July 1st to indicate that a drug amount was not wasted. Claim edits started on October 1st for these modifiers that now reject claims when the drug modifiers are used incorrectly. These modifiers apply on all claims reporting drugs separately payable under the Part B benefits that are supplied in single-dose containers or single-use packages based on FDA-approved labeling. In our example here, we have a patient with metastatic triple-negative breast cancer receiving Trodelvy. Now, Trodelvy is a weight-based drug, and our patient will require 950 milligrams. Trodelvy, however, only comes in 180 milligram vials. Therefore, we're going to have some wastage on this claim. We're going to indicate on our claim that the patient received all 950 milligrams of the Trodelvy by reporting 95 units of J9317 with the JZ modifier. We're also going to indicate that 130 milligrams of this drug was wasted by reporting 13 milligrams of the J9317 with a JW modifier. ASCO does have a one-page resource on drug modifiers on its coverage and reimbursement page that explains the drug modifiers and how to use them. Next is the J2211 visit complexity code. When CMS adopted the RVU values for the revised office and outpatient visits, the values, CMS didn't feel like these values fully accounted for resource costs associated with primary care and other ongoing care of complex patient conditions. The visit complexity add-on code was proposed in 2021 to offset the costs that weren't being accounted for in the office and outpatient services. The Consolidated Appropriation Act that year, though, bundled the payment for this code. However, effective January 1st, 2024, the status of the G2211 will change to active and separately reportable. Originally, CMS had estimated that up to 90% of E&M services would be eligible for this add-on code, but they've since revised their estimate to about 38%, mainly because this code will not be able to be reported with E&M services in which a modifier 25 is used. The G2211 will be reported in addition to a primary evaluation and management code for services that act as the continuing focal point for all needed healthcare services and or a medical service that is part of an ongoing care related to a patient's single serious condition or a complex condition. It should not be reported in cases where the care by the billing provider is routine or time limited. Reimbursement has been set at $1,604 for this service, which will be in addition to the reimbursement of the primary E&M code. Also in 2024, CMS is wanting to encourage addressing and managing social determinants of health. So CMS proposed and finalized a code set to support activities that address these conditions. The first of these services, community health integration, would be initiated at a visit, usually E&M, at which a problem is addressed and for which the social determinants of health are identified that significantly limit the problem. Certified and or trained auxiliary personnel, which include community health workers, would then address the social determinant needs in supportive activities that make up the community health integration service. Principal illness navigation is performed by certified or trained personnel in specific proposed areas and authorized to perform those activities by law. They must also be employed by the physician or qualified healthcare professional, either directly or in a contractual agreement. Now, these personnel may include cancer navigators, geriatric care navigators, social workers navigators, among others. The activities provided by these workers are similar to that of community health integration, but they focus on a serious high-risk illness. Community health integration and principal illness navigation services include many of the same activities. These can include communicating with all service providers regarding the patient's psychosocial requirements, preferences, and desired outcomes, building self-advocacy skills and educating the patient on how to best participate in medical decision-making, coordinating services and care transitions among all community and health-based providers and practitioners, facilitating access to community-based social services and healthcare access, providing social emotional support to cope with the problem addressed, their social determinant of health needs, daily routines, all in order to meet the treatment goals, In addition to social and emotional support, staff may also provide mentorship and inspiration. Finally, they will establish an action plan through a person-centered assessment. One activity that's performed as part of principal illness navigation is the identification and referral of the patient, caregiver, or family to supportive services. While both community health integration and principal illness navigation facilitate that access, only principal illness navigation refer the care to other supportive services. G0136 was created to report the administration of a standardized evidence-based social determinant assessment tool. This tool must assess the patient for food insecurity, housing insecurity, transportation needs, and utility difficulties. The tool may screen for other items that affect compliance and social needs of the patient, but it must screen for these items at the very least to report the code. Now, the intent of this code is not to screen all individuals. However, it's rather meant to assess a patient that has suspected or known social determinant needs and confirm those needs. In addition to specified training required, CMS did instruct on some certain criteria. So each of the services, both community health integration and principal illness, require an initiating visit, usually an E&M visit, but there are some other acceptable visits. And these would, at these visits, the social determinant of health would be identified for community health integration and principal illness navigation if it's applicable with the illness. Each code, all three, would require identification of any social determinant of health needs. Regarding time, the time spent furnishing activities to address the social determinants of health should be documented in the record for community health integration. The time spent in relationship to this serious high-risk illness would be documented for the principal illness navigation codes. A description of the activities is required for both community health integration and principal illness navigation. And it is important to note that while the services may be performed by auxiliary personnel, they are reported by a billing physician or qualified healthcare professional. The community health integration and principal illness navigation is subject to general supervision guidelines. CMS used the chronic care management codes as a basis for the RVU of the social determinant of health service codes. G0019 is reported for 60 minutes per calendar month of community health integration, and each additional 30 minutes would be reported with the G0022. Principal illness navigation is set up similarly to the community health integration. G0023 is for the 60 minutes per calendar month, and each additional 30 minutes would be reported with the G0024. There are two additional codes created in this code family, G0140 and G0146. However, they are restricted for behavioral health conditions only. Lastly is the social determinants risk assessment that's was created under G0136. This accounts for an assessment taking 5 to 15 minutes and shouldn't be reported more than once every 6 months. More than once every 6 months. Some resources that we have. So ASCO does have resources available on the coding and reimbursement page that correspond to information provided in this presentation, including written documents for the annual CPT update, the ICD-10 update, and quarterly HCPCS updates, along with the drug modifier resource that we mentioned. To find these and other resources, head to asco.org and select the coding and reimbursement. Select coding and reimbursement under the billing, coding, and reporting tab. While you're there, among the resources you will find are ASCO's tip of the month, the timely updates for CPT, HCPCS, and ICD-10 updates, guides for the 2021 and 2023 E&M updates, along with several practice administration guides for topics such as advanced care planning, care management, and coding and reporting for social determinants of health. We also have a comparison document that compares the care management codes with the social determinants of health codes that are new for 2024. Also available is the Medicare program page, where you can find resources on NCCI edits, Medicare contractor information, the RAC program and RAC audits, skilled nursing facility consolidated billing, and more. Additional resources that pertain to this presentation include that CMS MLN Matters article on CAR T therapy, as well as several articles regarding diseases added to the ICD-10 classification. Lastly, I would like to mention that ASCO offers membership for the entire cancer team, including practice administrators. Membership offers benefits like networking with other oncology professionals, advocacy tools, and educational opportunities like the one you participated in today. Any questions about the information we've covered here or any other coding questions may be sent to ASCO staff at practice@asco.org.